Um, oh, there's our recording. Um, and we would love to hear from you authentically. We invite you to speak from your own experience and to stay open and curious when we're hearing about others, and honor other people's lived experiences as well. Walter Gilliam is fully introduced in the video. The video is about an hour long. I had the pleasure of seeing this talk live, which was why I was really excited to talk about this. I was at the 0 to 3 conference in Long Beach, California last year, and he was one of the keynote speakers and gave the talk called The Health, Mental Health, and General Well-Being of Early Childhood Educators, Education Professionals, excuse me, beyond educators. And I walked away from this presentation just really feeling the need to talk about it. I walked, and because it was the end of the whole conference, everyone kind of scattered and went home, and I was like, I'm not done yet. I want to talk about this. So my hope today is that we'll all watch this together. It's about 50 minutes long. It'll start us off with a little bit of a grounding exercise and then jumps into his presentation. And afterwards, we'll have some time for quiet reflection and then some discussion about it. I have a shared note catcher for us all. And Cameron, if you could please put that in the chat. Um, you are welcome to take notes on this shared note catcher. If you'd prefer to jot down your own notes privately, that's totally fine as well. I know sometimes when I'm watching a video, I'd love to like, capture a quote or something that I know I want to talk about later. So I just put this together so we could capture some notes together. And without further ado, I'm going to get us started here. And I think it's quiet for the first moment here, so the sound should come on in just a second.
Welcome. I invite you to close your eyes gently. Take a deep breath in through your nose and slowly exhale through your mouth. Feel your body begin to relax. Bring your attention to your breath. Notice the sensation as the air enters your nostrils and fills your lungs. Feel your chest and abdomen rise and fall with each inhale and exhale. If your mind starts to wander, gently guide your focus back to your breath. There is no need to judge or engage with your thoughts. Simply observe and return to the present moment. Scan your body from head to toe. Notice any areas of tension or discomfort. With each exhale, imagine releasing that tension, allowing those areas to soften and relax. Feel the ground beneath you, supporting you. Sense the weight of your body, grounded and connected. Let this connection bring you a sense of stability and peace. Take a moment to feel gratitude for this time you've given yourself. Slowly bring your awareness back to your surroundings. Wiggle your fingers and toes. Stretch if you need. When you're ready, gently open your eyes.
Please welcome 0 to 3 Senior Professional Development Manager, Katrina Makasayat.
Good afternoon, everyone. I hope that you are feeling inspired and really making incredible connections with content and with each other. There's really nothing like being together in person, seeing everybody in person. So let's continue learning together as we hear from our science plenary speaker, Dr. Walter Gilliam. Dr. Gilliam is the executive director of the Buffett Early Childhood Institute and the Richard D. Holland Presidential Chair in Early Childhood Development at the University of Nebraska. He is a tenured professor at the Monroe Meyer Institute, University of Nebraska Medical Center, and adjunct professor at the Yale Child Study Center. We benefit from Dr. Gilliam's leadership as the current president at the 0 to 3 board. His field leadership also includes being a past president of Child Care Aware of America, board treasurer for the Irving Harris Foundation, a director for First Children's Finance and the National Workforce Registry Alliance, a former senior advisor to the National Association for the Education of Young Children, and a senior fellow at the Bipartisan Policy Center. Dr. Gilliam may be most known for his work on preschool expulsion and suspension, early childhood mental health consultation.
Rebecca, we can see your note
gender
page.
bias in early childhood settings. And in 2008, Dr. Gilliam was co-recipient of the prestigious Grow-Meyer Award in Education for the co-authored book, A Vision for Universal Preschool Education. He is frequently quoted in major national and international news outlets and actively provides consultation and invited testimony to decision makers in the United States and other countries. It is my distinct honor.
Did that correct it? Just a moment. I was trying to pull up our note catcher so I could participate in capturing notes. And now I have too many screens in front of me. Sorry, everybody. All right. This full screen. Okay, now can we see the presentation?
Yes.
Followed his work for years. It is my distinct honor to welcome to the stage a luminary in the early childhood field, Dr. Walter Gilliam.
Hello, everyone. I can almost see you. How's it been going so far? Are you happy to be here in California? Are you happy to be among like-minded people who care deeply about children and families and those who care for them? To be able to celebrate that which we care deeply about, but also others who care deeply about them as well as us. You know, that is what we are here for today and tomorrow, and that's what we're here for for a long time to come, because many of us have dedicated our careers and lives to the work that we do. And so for that, I'll thank you up front for everything that you do that would put you in this seat today, next to somebody else who cares deeply about helping others and being all that we can for our babies and their families and their communities. Now, I'm going to have to say up front that I'm going to start out a little heavy on this, and we're going to be talking about some data, and some of the data might be a little hard to hear. And I'll apologize for that up front. It will get a little bit easier as we go, and then unfortunately it might get a little heavier again. But I promise that I will do my best to end with a hopeful note, because all of this work is about hope. How many people have ever looked into the eyes of a baby and thought, that right there is hope? That right there is hope. So anyway, at the very beginning of the pandemic, there were a lot of people who were concerned about childcare programs and whether these childcare programs would be able to stay open, whether or not people would be able to go to work. I remember that I was concerned. At the time, I was a professor at the Yale School of Medicine, and I was concerned at the beginning of the pandemic that we might not even be able to keep the hospitals open. Like what would happen if somebody needed to come to the hospital at the beginning of the pandemic and they needed to be seen, but the pulmonologist couldn't come in because the pulmonologist couldn't get childcare. There was nobody to take care of the pulmonologist's baby. Or what about the respiratory therapists or the nurses? Or what about the amazing people who work in environmental services, keeping those places clean and sterile enough to be able to see patients? Or the people who work in the cafeteria? Many of them need childcare in order to be able to come to work. And I remember being concerned about that. And we collected some data and showed the number of childcare slots that would be necessary in order for us to be able to keep open enough childcare to be able to keep the hospitals open. And we put that data out about a week into the pandemic, and 28, I think, US senators signed a letter demanding $3.5 billion in the original CARES package be pulled out and set aside specifically for emergency childcare for essential healthcare workers. And they were able to get that in the first week. And that was a good thing. But then, and I mean, I'm going to start sounding like I'm a little neurotic maybe. Then I started worrying, what did we just win? Did we win the opportunity for childcare providers to put their lives at risk providing childcare? And so I became worried about that. And then when I was worried about that, I thought, well, what kind of data do we have on what kind of risk there is in providing childcare during a pandemic? And we really didn't have any, and I couldn't find anybody who was actually starting to collect data like this. The government didn't seem to be setting up any large-scale studies, which kind of surprised me. And so we started turning our attention to large-scale epidemiologic studies, and that's what I'm going to be telling you about during most of this presentation. We now have about 126,000 early care and education providers that are participating in this very large multi-wave epidemiologic study that we've been conducting since the beginning of the pandemic until now. And I'll be sharing with you some of the results that we've been getting from that. And of course, it has been evolving over time. In a way, this is the central question. But in a way, one can argue that this central question really isn't framed correctly. Maybe it isn't really about how well are those who care, but how well do we treat those who spend their life caring? That might be the bigger question, And so when you hear us talking about this, please think about this not just in terms of the wellness of the field, but how well we treat that field and what it is that we do and fail to do that might put them in the position that they're in. So there was this study that came out near the beginning of the pandemic, and it was a study looking at the number of deaths during the first year of the pandemic based on occupational code. So they were looking at death certificates, and then they were looking at the occupational code for the person who had passed away. And what they had found was that there were certain occupations where the death rate was much higher than other occupations. And this one reporter from Chalkbeat contacted the researchers and said, I noticed that you pull out teachers and talk about teachers in relationship to other occupations. Can you look specifically at childcare professionals and pull them out separately? And they said, well, yeah, we could pull them out separately. And so when they did, what they found was that there were 405 childcare providers who had COVID-19 or COVID-19 complications listed as a cause of death. And when you divide that out by the number of childcare providers in the United States at the time and get a rate in terms of number of COVID-19 related deaths per 100,000, the number for childcare professionals is 38. The number for all other essential workers combined was 30. For all workers, essential or non-essential combined, the number was 25. And the number specifically for non-essential workers was 16, which happened to be exactly the number for K through 12 teachers, 16. K through 12 teachers, most of them were at home at the beginnings of the pandemic. And so what you see from this is this much higher rate of COVID-19 related deaths and a much higher likelihood of COVID-19 related deaths if someone were a child care professional, which then raises the question of, well, why? Why would that be? Why would that be more likely to occur? Now, before this actually came out, we had already been putting together data on COVID-19 transmission in child care programs and released the first wave of that study in October of 2020. And what we did was we surveyed childcare providers all across the United States, all 50 states, about 3/4 of the nation's counties. And in our first wave, we had a little over 57,000 early care and education providers. Now, it just so happened to be when we were collecting this data, which was at the end of May and the beginning of June, during that couple of week period at the very end of May to the beginning of June, when we were collecting the data, we were only just about a couple of two and a half months into the pandemic. So the pandemic hadn't really been here for long. And I knew that in order to be able to do a study like this, we were going to have a massive sample size. So we were going to have tens of thousands in this study to be able to look at COVID-19 death rate or COVID-19 rates of transmission and whether or not that had anything to do with childcare providers. But it just so happened that at about that time, roughly half of the childcare workforce had stayed in business and had been seeing children. And about half of the workforce had not been, which gave us, for terrible reasons, this important moment to be able to actually look at whether or not exposure to childcare was related to contracting COVID-19. Now, I have to say, it was a little painful for me to even think of the phrase exposure to childcare, because it sounds like you're talking about childcare as some kind of toxic thing. But to do a study like this, I mean, that's how we had to think about it. It was a potential contagion, childcare. And if you were exposed to childcare, would that increase the likelihood of you catching COVID-19, have COVID-19 complications, be hospitalized? And so when we were doing the study, what you do is you collect lots and lots of data. And one of the variables that you ask about is whether or not they've been ever diagnosed with COVID, tested positive for COVID. You would ask whether or not they'd ever been treated for COVID, been hospitalized for COVID, intubated for COVID, all of those kind of things. And then you identify your COVID cases. And then statistically look for a large number of matched controls, people who are demographically identical to those who had contracted COVID. including identical based on the amount of COVID-19 transmission that was happening in their community. Johns Hopkins University was already collecting COVID-19 data within communities. And so we could control for the amount of COVID that was floating around within their community. And also then, because we were asking questions on this, control for whether or not they'd masked, whether or not they were canceling events, whether or not they were taking other types of precautions. And then in the process of doing that, ultimately end with a bunch of cases, individuals who had actually developed COVID, compared to a large group of people who were demographically similar and had the same amount of COVID exposure within their community and were taking the same amount of precautions. And that the only difference that we were isolating down now was whether or not they were exposed to childcare. And when we did that, what we ultimately found was that childcare programs were doing an awful lot to mitigate COVID-19 spread. They were disinfecting just about anything that didn't move. They were having parents leave their children off at the door, and then they were escorting them in themselves. They were cohorting children, keeping children together in pods so that they don't mix too much. And then they were literally having to do the opposite of everything we've ever said about meal times and family meals by serving them their meals quite separately. And they were doing all of this in order to keep these children and themselves safe at the beginning of the pandemic. So we have to take all of this within the context of that. And when we look at it from that perspective and we analyze the data, what we found was that there were no differences between being exposed to COVID-19 or not being exposed to COVID-19 in terms of the likelihood that you would actually contract COVID-19, or I'm sorry, exposed to childcare versus not exposed to childcare in terms of whether or not you'd be likely to contract COVID-19. So we found absolutely no differences. So what you could conclude from this is this: childcare didn't seem to pose any threat to the community in terms of transmission of COVID-19, but we did find a lot of evidence to suggest that communities posed a lot of threat to childcare. You know, and so instead of closing down our schools, maybe we should have closed down the bars and some of the rallies. But anyway, that's what we had found. Now, the other things that I can say that we had found too were that clearly some families that were providing childcare were carrying a heavier burden of COVID-19. That many of our childcare providers of color were far more likely to contract COVID-19. And childcare providers who earned less money were more likely to contract COVID-19. And childcare providers who maybe had a partner, an adult partner in their home or spouse, who also was an essential worker, were more likely to catch COVID-19. So it didn't seem to be the working conditions of the childcare program, seemed to be other things. And so combining what I'm telling you right now with that study about death rates, what seemed to be at play here is this: childcare itself did not increase the likelihood of childcare providers getting sick and perhaps even dying of COVID. But the way we treat them and compensate them, and how much access to healthcare they are able to get because that's a benefit or not a benefit of their job, and how well they're able to afford to be able to live in a home where they could segregate versus be in one where there's not enough space to be able to segregate, to keep yourself distant from another family member who might have COVID. All of those kind of things that have to do with not childcare itself, but how we treat and compensate and support childcare providers. That seemed to be what it was that was driving the increased rate at which childcare providers were dying of COVID-19. So when we continued collecting data, we were collecting more and more data. We had this study that came out with data from May and June. We had about 82,000 in it, and you can see what the rate of various different illnesses were as reported to us by childcare providers. I bolded the asthma rate there because that's about 20% higher than what you would typically expect for an adult female population in the United States, which then raises the question, why is it that childcare providers are more likely to have asthma? And so we've been attempting to start up a study with some colleagues at Yale, looking specifically at that question by fitting to childcare providers monitors, passive air quality monitors that measure the quality of the air they breathe in their childcare program, as well as the quality of air that they would breathe when they're at home and in their community. Because quite honestly, many childcare programs are not just figuratively in the basement. They are, in many cases, literally in a basement with lots of mold issues and other things that might contribute. We also started collecting more data, not just on their health, but on mental health as well. And you can see here from 2020, as well as from 2021, rates of depression and rates of moderate to severe stress. Now, by rates of depression, what I mean here is screening positive for potentially diagnosable levels of depression using the Center for Epidemiologic Studies depression scale. That's a measure that many people use to estimate diagnosable rates of depression within a population. At the beginning of the pandemic, 46% were screening positive for depression, potentially diagnosable levels of depression. A year later, that 46% became 56%. More than half of the teachers in early care and education programs potentially diagnosable with major depression. That's incredible to think about. You know, I don't want us to look at a number like that and think about it briefly. I want us to ponder that. I'm not talking about 46, 56% saying I get sad every once in a while, or that every once in a while something bothers me, or that occasionally I can't sleep well. I'm talking about 46 to 56% diagnosable with depression. I mean, that's quite significant, really. And you can't sustain a profession where the majority of people in it are diagnosably depressed. And when you look at moderate to severe stress, this is pretty high levels of stress that we're talking about. Stress so severe that it could actually compromise one's health status, compromise your immune capacities, and make you more likely to get sick, going back to what we were talking about just earlier. We also noticed this, that depression and stress were highly related to both work stability and pay stability. So if you were to think about it this way, individuals who are childcare providers who never lost a day of pay, never lost a day of work, never lost a dollar of pay, versus those who lost some work, but they were still paid, versus those who lost work and pay, versus those who completely lost their jobs. That mirrors increasing levels of depression and increasing levels of stress, except for one group. There was one group for which that absolutely was not true, and that group was child care directors. Now ponder that for a second. Why do you think it was that child care directors didn't show that same pattern? I'll tell you why. When you looked at the data closer, it was because their depression rates really couldn't go up much more. They were jacked up high to the top from the very beginning. There was literally no place left for their depression and stress to go. Because when people were losing their jobs in their childcare programs, it was them who were having to tell it to them. Their stress levels were so high, they didn't have any place else to go. They only went up if they themselves lost their job because the whole program closed. That's what we ultimately found in terms of the relationship between stress and depression and pay. Does it surprise anybody? Give me a wahoo if it surprises you that pay and depression are related. I'm not hearing any wahoos on that. Here's what we know from the first 3 months of the pandemic: 35% of the workforce was without a job. So 3 months into the pandemic, out of a job. I don't mean occasionally told not to come in. I mean they had no job left. And of those who did have a job, about 54% of them experienced at least periodic closures during the first year. So what I was saying before about this instability of work and instability of pay was really very much the case for an awful lot of them. They didn't know what to expect from 1 minute to the next. There was a study that was done by Daphne Basak at the University of Virginia. She collected the data just before the pandemic. It became a study that a lot of people knew about during the pandemic, but the data were actually collected just before it. So it's not really pandemic era data. And what she was interested in is they had this PDG dollars in Virginia, and they were able to give some people an extra bonus, a retention bonus. We'll give you $1,500 more if you'll stay in the field another year. That was the study. And so what they did in study one was they randomly assigned some individuals to get the $1,500 and some they didn't. And what they said was, if you stayed in the field for another 9 months, we'll give you the $1,500 at the end. And then they looked at those who got $1,500 versus those who weren't promised $1,500. And they found that it reduced dropout rate from the field from 24% down to 13%. That's a 46% reduction in the amount of dropout, 46% reduction just by giving just $1,500 to somebody. Then they did a second study, which I thought was just absolutely ingenious. They studied, well, what about the timing of that $1,500? What if we said in group one, you have to stay in for the full 9 months, and then we'll give you the $1,500 at the end if you make it. And then the other group, they said, we're going to give you $500 every 3 months. And then they looked to see which group stayed in the field more by the time 9 months was finished. So what would you think would be the group that would outperform? Would it be the group that was told, if you stick it through for the 9 months, then you'll get the big bonus? Or was it the group that was given $500 every 3 months? Now, I've already given you the answer, it's right there. But a lot of economists would listen to that and say, oh, clearly, if you make them wait to the end, it's a better incentive. But it didn't work that way. It worked the opposite. Why did it work the opposite? Because an incentive is only an incentive if you want it, but you don't need it. If you need it just to live, it's not an incentive. And with the rate that we pay our early care and education providers, $1,500 wasn't an incentive. It's what they needed just to be able to get by, just to be able to make it to the end. So we did another round of our study, and we asked teachers who had already left the field, if we had offered you $500 to stay in the field for another year, would you have stayed? And based on the results, it would have suggested about a 20% decrease. Now, we set up the Qualtrics, this is an online system for surveying, in a way to do something a little different than what Qualtrics typically does. We set it up to where if the person answered yes to the question about $500, then they would go on to the next set of questions. If they answered no, then the next question was, well, what if it were 1,000? And if they said yes, then they go on to the next set of questions. And if they say no, then the next question was, well, what if it were 1,500? And we basically were auctioning it off. Like how much would it have taken for you to be able to stay in the field? And what we found was that you had to get up to about 3,000 to get the same rate that Daphne Basak was finding just before the pandemic. So retention bonuses could help to keep people in the field, but the going rate right now, post-pandemic, has just doubled. So it will cost you more. It will cost you about 3,000, not 1,500, to be able to get that. Now, when we first started collecting these data, we then, released the data. I made a promise to child care providers at the beginning of the pandemic. We were working with the National Workforce Registry Alliance, and we were working with state child care registries. And we made a promise to them and a promise to the child care providers that we had invited into the study, that whether or not you participated, if you participated, great. If you didn't participate, great. Either way, when the data are ready to release, we are going to have a webinar, and you are all invited. and we will release the data to you first, and then it will go out. And we decided to make good on that. And when we did that, we ended with asking them, what is it that we have not collected that we should? Because there is power in being able to answer questions, but there is more power in being able to actually make the question. And that's where the power should reside. So we were trying to do a very large, full community participatory study. So we had about 6,000 people on the webinar. So it was a pretty big webinar, and we got lots of information, and that led us to add some questions that we did not have in the epidemiologic survey before. Another way in which individuals in our field could be harmed. In this case, harmed through being exposed to racialized aggression. Because that's what we heard from some of them, actually from quite a lot of them. And so when I'm thinking about and talking about racialized aggression, what I'm talking about here is aggression that was directed at them or at somebody they loved or that they eyewitnessed, that was racial in its focus, that it called out race in some kind of way, or it was in some kind of a racial context, could be either verbal or physical. Did you get exposed to this within the past year? And we were doing this, during the pandemic, so not very long after the murder of George Floyd, not very long after the very beginnings of the pandemic, where many people in very high positions were saying things that were incredibly inflammatory regarding the origin of the virus. And there were many people who were experiencing and reporting to us lots of ill thought and aggression towards them because of that. And so when we asked this question, ultimately what we found was about 29% said, yes, I've experienced that, either directly or indirectly in the past year. And then you can see some groups reported the highest rates: Asian American, African American, multiracial. Now, we collected the data in a way to mirror the US Census data, which pulls out Latino, Hispanic as a separate issue, as a separate from race, and being about ethnicity. So we are still in the process of analyzing that. And so I apologize that we don't have that broken out here. But following US Census Bureau conventions, this is how the exposure rates dropped out. Now, if we asked whether they were the direct target of it, then it came out this way, and you can see who was reporting being the target of racialized aggression. And then we started looking at the relationship between depression and stress and racial identity. Now, we found that at the beginning of the pandemic, there were some individuals who identified as persons of color were reporting significantly higher rates of depression and stress than individuals who weren't. And for some groups, that rate was particularly high. And so we were curious as to whether or not during the course of the pandemic, did one's racial identity further increase depression, further increase stress. And what we had found in the study is this: it didn't. There was no relationship between racial identity and increasing depression or increasing stress. However, if we created an interaction term between their self-reported racial identity and whether or not they feel they have been exposed directly to racialized aggression, that interaction term was significantly related to increasing depression and increasing stress. In other words, the data showed us that racial identity did not predict increasing depression and stress, but racism did. That's what we ultimately found. So it wasn't one's identification of race, it was It was one's experience of racism within the group in which they were identifying. And that we found that this was specifically true for childcare providers, early childhood education professionals who identified as African American or Asian American. Those two groups in the first half of the pandemic were reporting significant rates of exposure to racialized aggression, and that exposure to racialized aggression for those groups was highly predictive of increased depression and stress over the course of the pandemic. 1930, let me back up. How many people have heard of the term the whole child? So a lot of people have heard of that. That term was first coined in 1930 as part of a conference on child care and children that was hosted by the White House in 1930. The term's been around for a very long time. I think it's time for us to be talking not just about the whole child, but the whole child care provider, the whole child professional, to not just think of those who care for our children as curriculum conveyance mechanisms, but as actual human beings who experience life and who, as a result of those experiences, are going to walk into a classroom and carry that with them because they are wonderful, amazing, complex human beings. And that if we don't think of them as human beings, then it's going to be difficult for us to be able to support them well enough for them to be able to support our children as well as they would like to support them. So along those lines, let's talk a little bit about how well our young children are doing. So we asked these childcare providers about the children in their care. Now take a look at this. This is all data that were collected in 2021. And we asked them whether or not the children, compared to before the pandemic, were more externalizing. Externalizing meaning acting out, hyperactive, oppositional, defiant, breaking the rules, engaging in challenging behaviors. You've heard that phrase before. So what we found in 2021 was that 64% of the teachers said, yes, the children in my classroom are more like that, are more acting out than they were before the pandemic. And 22% of those said, heck, that's true for half or more of the kids in my classroom. We also asked them whether or not the children were more internalizing, shy, withdrawn, clingy, teary. And 63% said, yes, that's true. The children in my classroom are more like that than they were before the pandemic. And 15% of them said that's true for half or more of the kids in my classroom. And then we asked them about whether the children in their classroom were more likely to be showing signs that are perhaps somaticizing signs, ways in which children might show stress in their bodies, whether or not they were more difficult to feed, that they were having a harder time waking up, going to bed, taking a nap, that they were having more daytime accidents with toileting, all the ways in which stress inside the body of a child may show up in the classroom. And the teachers, 49% of them, almost half of them said, yes, children in my classroom are having more of these kind of symptoms than before the pandemic. About 12% said that's true for half or more. So that was what it was in 2021. We asked the same question again in 2023. Now in 2023, we're now 3 years past the beginning of the pandemic. You'd think it would have gone down, right? It went up significantly, such that at the beginning of the pandemic, or a year into it, 64% said, yes, the kids in my classroom are more acting out than before. Well, 2 years later, almost half, 46%, said half or more of the kids in their classrooms are like that. Because we started getting to a point where we were enrolling more children in classrooms and trying to keep the classrooms open. But we did not have the supports necessary for the teachers to be able to succeed, especially if the teachers themselves were dealing with their own depression and stress. And so that's what we were ultimately finding. Children have this way of taking all the stress of their homes, their communities, their families, putting it in a backpack, going to school, and dumping it out onto the table for the teacher to look at. And you know what? Adults do that too. Put it all in our backpacks and in our pockets, and then we come and we dump it out. And if the children are coming in, they're dumping that all out for the teacher to sort through. The teacher's on her last nerve. You know, somebody's going home early today. You know, and I've studied that. So, you know, like that's what I think we were ultimately seeing at the beginning of the pandemic, but I think it's what we're seeing right now. We asked teachers who had left the field. So we did this longitudinal wave, we had about 25,500 in the study, of which close to 4,000 had already left the field. And so we gave them an exit interview. We asked them, why'd you leave the field? We asked them all kinds of different types of questions. And the number one reason is what I would imagine many of you would suspect. It was low pay, you know, followed by not enough respect, lack of benefits. Lack of benefits kind of related to pay. It has to do with the compensation package. And then you have not enough support for challenging behaviors, up there rather high in terms of as a reason why early educators would actually leave the field, but they're not getting enough support for children in their classrooms with challenging behaviors, especially when they themselves might be struggling with their ability to be able to manage challenging behaviors. Have you ever woke up in the morning and you thought, you know, I'm feeling really good today, and today I think I can take on anything? Have you ever woke up in the morning and thinking, today is not the day for you to be bringing me that problem? I mean, how many people have ever felt that way when you wake up in the morning? You know, like, can you imagine feeling that way almost every day though? And then you come into the classroom and then there's a lot of children there and they have, in many cases, experienced trauma in their homes and in their communities, job loss. They're bringing you a lot, you know, and that's the recipe that we had during the pandemic. Now, we've done several studies on the effects of early childhood mental health consultation, and we know that when you put an early childhood mental health consultant into a classroom working with a teacher, that it can have huge impacts on what happens in that classroom. And in part because you're helping the teacher be able to manage challenging behaviors, but you're also maybe helping the teacher feel better in her own capacity to be able to manage that. That you're helping address that teacher's stress level too. During the course of the pandemic, we asked providers whether or not they had access to early childhood mental health consultation. And you can see here that when we're asking about whether it's regular access or on request access, that 43% of Head Start and Early Head Start reported that they had some kind of access. And then you can see what the rates were for schools. And then when you get out into childcare centers in the community where they're less well-resourced, you can see that the rate is much, much less. And then when we ask specifically about regular access, not just some kind of access, but regular access, if you need it, you could get it right now. What we found was this. During the course of the pandemic, in classrooms that were serving a majority of children who were white, the rate went from 5.3% having access to mental health supports at some regular level to 5.3% later. The rates did increase for classrooms and programs that were serving children who were majority children of color. However, and that's good. However, before we pat ourselves on the back too much with that, let me change the scale from 0 to 100%. And the true story is here. Almost nobody gets any of this anyway. The rates are just so abysmally small in terms of mental health supports in classrooms. And if there was ever a time that we needed to be able to provide mental health supports in classrooms, it is right now. When we have our early care and education providers who are struggling so much, and our families who have been struggling so much for so long in so many different ways too. How much we truly care for our young children can be measured by how much we care for those who care for our young children. Our children's cups are filled to the degree that some care provider's cup is overflowing. That's how the water gets there. It gets there by having early care and education providers, care providers. And that could be parents, and that can be child care providers whose lives are so overflowing that there is something left over for the children. And if that is not the case, then it's kind of hard to imagine how they'll be able to provide the level of care for our children that I know that they want to provide, because we haven't been providing enough for them. During the course of the pandemic, the issue of well-being of the childcare workforce has become incredibly important. Many people are talking about it. I wish they were talking about it. I wish they were talking about it because we simply value those who provide care. I think the reality is many people are talking about it now because we provide the care that they provide. That's what we value. And we know that we need to be able to keep them happy enough and compensated enough to keep providing care. I was on a Zoom call at the beginning of the pandemic with somebody who said something that made a lot of sense. They said, you know, at the very least, there's now a lot of people who now value childcare because they see what's happened when there's not enough childcare provided. Businesses can't stay open. And so now we're in a moment where the public values childcare. Excuse me. Excuse me. I'm back. I choked myself up on that. Literally. And at the beginning, when I first heard that, I thought, well, that makes a lot of sense. People have now seen, you know, what happens when you don't have childcare. But then I thought, well, you know, up in the Northeast where I was living at the time, people see what happens with no childcare every time it snows. You know, like, so I don't know if that's completely it. Maybe the issue is this, that it's not about valuing childcare. If anyone values a commodity, a product, or a service, and you respect the individuals that provide that product and service, then you negotiate. But if you value the product or the service and you don't respect the person who provides it, then you exploit. And maybe that's really what has been happening. That maybe that's what's been happening for a very long time in a field that is 96, 97% women, and in many communities, disproportionately women of color. That we don't have enough respect to negotiate, and we exploit on the basis of the fact that we know that they are doing it because they love children. And we take advantage of that. And in the process, we don't compensate them well enough. We don't treat them well enough. And as a result of that, it will be difficult for them to be able to provide the care for our children because their cups are not flowing over, because we have not been filling them. And that ultimately was, I think, what we were finding with the studies that we've been doing. We can do better. I know we can do better. If we love our babies, we have to love those who care for our babies. If you love babies, if you love young children, then you have to care about women's issues. If you love children and babies, you have to care about the issues that affect providers of color, because those are the people who are caring for those babies. And so if there's anything that I've said here today, you know, please let it be the one, please let the one thing that's remembered be not me almost coughing, but instead being the fact that you can't care about babies unless you're caring about those who care for those babies. So I'm going to thank all of the funders for this work. I'm going to thank the National Workforce Registry Alliance. That's a great group. They represent all of the state childcare registries. Without them, we could have never had these data. I'm going to thank 126,000 early care and education providers who participated in these surveys. I was asking them a ton of questions at a time when they had very little left in their cups, and they kept answering the questions anyway. And I'm going to end by saying thank you to you. I don't know why you're here exactly. Maybe it's because you're a child care provider. Maybe it's because you're a mental health care provider. Maybe it's because you're an administrator. I don't know, but I do know this. If you're in a place like this today, it's because You are caring for children and families and those who care for them. So for whatever it is that you do in your daily lives, thank you, thank you, thank you.
Okay. And now I just had to leave the conference and go home and not talk about it for a whole year. Um, so I would love for us to just take a moment. I know that was heavy. Let's take till 11:10. We'll take about 12 minutes to take a quick break, do some quiet reflection. I have some questions here. Feel free to use your own journaling method or the shared note catcher, whichever you'd prefer, and we'll come back at 11:10. Alrighty, we will come on back. If everyone could please put in the chat, how are you feeling right now, or what's sticking with you in this moment? Maybe just a word or feeling or something that's going on in your mind. I see curiosity. If you love babies, you must love the adults who care for them. Reflective, intrigued, want to work with kids again. Seeing hope in babies' eyes. Alrighty, well, thank you. If anyone wants to voice anything now, you're more than welcome to come off mute. And I'll give just a quick pause and then we'll go into breakout groups for more discussion. Anyone have anything burning that they want to share at the moment? Alrighty. It was a lot of information. I'm going to put some discussion prompts in the chat and then we'll go into breakout groups. Cameron, if you wouldn't mind prompting us for breakout groups. And the discussion questions are suggestions. Feel free if the conversation strays, that's totally fine. When we come back, I'd love to hear from each group just kind of where the conversation went or any takeaways that would be good for the whole group. So if you can keep that in mind while we're in our discussion groups, if someone wants to take notes or be the one to share when we come back, that'd be great.